with him, and I'm still learning from him. I'm so proud to be in his team, and I would like to thank him for his support for this webinar and pass the floor to Professor Aaaq. Thank you.
Thank you, Elif. It is an exciting day and also an important date for us because 14th of March, that's tomorrow, is a very important date from medical education of Turkey. So I welcome all of the distinguished speakers and the attenders to this meeting. First of all, I would like to thank Elif, Professor Elif Ekmekçi, for effort to organize this meeting webinar. It is actually a great pleasure for us to host you in this webinar, but actually we wish to have this meeting face-to-face in Ankara. I hope in future we can manage it when the pandemic is over. I hope this meeting initiates new collaborations and scientific research. Once more, I would like to thank to all distinguished speakers for their support to this meeting. And I wish, I hope in future we can publish the proceedings of this meeting. This is my word. Now, I hope the shortest is the best. So I give my words to Elif Ekmekçi, Professor, and invite Elif so we can continue the session with her valuable contribution. Please, Elif, it's your turn.
Thank you. Thank you so much. Thank you so much for joining and supporting us today. Now, I'll introduce you with a bunch of great young medical students who made this event possible. Could you please put our photo on, Irmak or Banu Hocam? These young people are the executive committee of Top Etu UNESCO Bioethics Unit Student Association, and they worked so hard and extremely effective for this meeting. So you're seeing the team. These are our great students, and they are the, as I said, executive committee. And also you're seeing Dr. Banu Brook here. She's an extraordinary person and a brilliant bioethicist, and I feel so lucky to be in the same team with her. And I would like to thank all the students, Begüm, Irmak, Sümeyye, Can, Emre, Ebrar, Manolya, and Ece, for their hard work in this webinar. Thank you. You can stop sharing. Thank you again, guys. So moving forward, it has been a year since the pandemic started, and the research community, scientific integrity, medical services, and public health is challenged greatly by this worldwide public health emergency. Today, we'll discuss about the value-based decisions during pandemics, and we'll have a deep dive into the implications of pandemics in the ethical realm. Our keynote speaker is Harry Silverman. Anyone who has been interested in bioethics or research ethics might have heard his name. He's a professor of medicine at the University of Maryland School of Medicine, and he received his MD degree at the Johns Hopkins University and his MA degree in bioethics at Georgetown University. He has been the chair of the Clinical Ethics Committee at the University of Maryland and Medical Center since 1990, and is a program director of Fogarty International Institutes of Health training programs focused on building capacity in research ethics in the Middle East since 2005, and in Myanmar since 2015. He is the principal investigator of a WHO grant to conduct research in Myanmar to address health inequalities caused by COVID-19 pandemics, and he is the senior editor of a multi-author compendium, Research Ethics in the Arab Region, published by Springer. So I would like to thank once more for accepting our invitation today. Professor Silverman, the floor is yours. Thank you.
Okay, you'll see me in just a few seconds. Well, I guess you see me now. Well,
yes, we do.
Thank you for that wonderful introduction. So let me share my screen. Let's see if we could get past the technology here. And okay, good. Well, first, I want to thank the organizers of this meeting and Professor Ella for inviting me to this program. I am deeply honored to be here to share some words with this wonderful group. So today, I would like to talk about research to address inequities caused by the COVID-19 pandemic. And so I'd like to first ask a question on the poll here. So regarding the pandemic of 1918, the following is often stated regarding that pandemic flu. The virus does not discriminate. It hit the rich and poor alike. So please vote, true or false? And we'll give a few seconds for you to vote. And right, we don't see this in real time, so I think we'll close the poll in about 15 seconds, something like that. All right, so could you show the results? Okay, so 62% said true and 38% said false. So almost even, but most people are saying that it hit the rich and poor alike. I think the issue is actually, what do we mean by the word hit? Does the virus not discriminate? Well, I think we could all rest assured that the virus does not discriminate, and that. But the issue is people's circumstances when they are exposed to the virus. So these are some research from the 1918 pandemic. We see here that. We see this slide here that this is the incidence, and we see this curve here is the poor and the very poor and the well-to-do and the moderate, and we see that the incidence is much higher in the poor and the very poor. If we see this slide here, this slide represents mortality, and we see the economic status of the household, well-to-do, moderate poor, and very poor, and we see that mortality of the very poor is much higher. So it's actually data that are very similar to the data being generated in the pandemic flu of 2020. So the issue is, what are the sources of the disparity for doing pandemics? And I think we could boil it down to three different categories. One, there are differences in social positions based on income, wealth, education, occupation, race, and ethnicity. And we have disparities in exposure to the influenza virus. Essentially, the poor and people from the lower economic strata of society find it very difficult to social distance. There are disparities in the susceptibility to contracting the influenza. People from the lower economic groups have lower immune systems. And then there are disparities in treatment once disease has developed. Also, there are disparities in access to health services. So all of this adds up to unequal levels of illness and death. And essentially, we have differences in the social context and also in the policy context. And so what I want to introduce before I go to the meat of my slides is we have a difference between equality and equity. What is the difference between equality and equity? So in this slide, we see equality means equal treatment. People should have equal resources and equal opportunities. However, equity recognizes that each person has different circumstances and allocates the exact resources and opportunities to reach equal outcomes. Essentially, because of the different circumstances, even if people have equal resources, they may not have equal outcomes. So let me, for those people who like pictures, this slide shows the difference between equality and equity. And so what we have here is we have people with equal, we have people with equal resources to have the same boxes in order to see this baseball game. However, not everybody have the same circumstances, and we see there's a difference in height. So in order to enhance equity, we give more resources to people who have different circumstances. And so now there are equal outcomes. Now, this slide, what's wrong with this slide in trying to demonstrate the difference between equality and equity? Well, the issue is that, well, one could say that this person here needs more resources, not because of social circumstances, but because of a difference in height. So this slide is not perfect to demonstrate the issue between equality and equity. So essentially, we're looking at concerns with social circumstances and policy, and not necessarily biology. So this slide, I like this slide better because here we see people with the same height, and they have equal resources, okay? But this person here doesn't have the same outcome as the other people, and the reason for that is because of a concern with social circumstances. So this lower level here represents inequities due to social circumstances, and because of the issue here with social circumstances, this person needs more resources in order to have an equal outcome. And so essentially, social systems are not naturally inequitable, but are rooted in discriminatory practices and beliefs. Equity means an absence of avoidable differences among groups of people. And equity is a solution for addressing unjust, imbalanced social systems. And well, so here's another slide showing socially disadvantaged neighborhoods. Here we have two neighborhoods with equal community resources. So we have equality, but we have inequities because this neighborhood does not have equal outcomes. So in order to have equal outcomes, we need more community resources for this neighborhood here. Now, be that as it may, not everyone believes that equity is a just solution. This article from a recent Wall Street Journal, equity is a mandate to discriminate, essentially saying that giving more resources to people in different social circumstances is actually a mandate to discriminate. And we have other sayings from this newspaper saying that the, let's see now here, say America's founders drew on those roots, declaring it was self-evident that all men are created equal, and there is a concern that claims for equal treatment are so deeply rooted in U.S. history. It is why radical claims for unequal treatment must be carefully buried in word salads praising equity and social justice. Also, if the results are not equal, they assume unequal opportunity. There is a concern that the reason why we have unequal outcomes is because there are differences in the work ethic and effort to achieve the unequal outcome. So there is this running disagreement as to, do we have different outcomes because of social circumstances, or do we have unequal outcomes because of different effort? That will always be a running battle. However, let's assume that the reason why we have unequal outcomes is because of unjust discriminatory mechanisms that affects people in the lower social economic groups. Based on experiences with previous pandemics, it is reasonable to assume that pandemic influenza can cause case fatality rates for some groups that are significantly higher than the rate of higher risk groups. It may become evident during a pandemic that a particular demographic group or groups with compounded social vulnerabilities may prove to be exceptionally at high risk of death. So why address inequities? What is fairness? So essentially what we have, if we fail to take steps to mitigate health disparities, our society will look different at the end of the pandemic. Who will be missing because of disproportionate deaths due to disproportionate impact of the pandemics? And essentially what we have from Martin Luther King, injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality tied in a single garment of destiny. Whatever affects one directly affects all of us indirectly. So what are the threats from the pandemic that causes unequal outcomes? Well, we have the direct health impacts from the virus. We have disproportionate impact from public health measures and the health systems, and we have disproportionate economic impacts as well. This slide shows the change in employment due to the pandemic in this past year. We have the change in jobs or employment between the wealthiest and the bottom level of society. We see that the lower paid jobs in the service sector were permanently lost among the poorer people. And we see that the return to employment was much lower in the bottom 25% of our society. So essentially, the concern is the disproportionate impact of the virus. The COVID-19 disproportionately affect the poor, minorities, and a broad range of vulnerable populations. The collateral effect of the pandemic due to the global economic downturn and social isolation and movement restriction measures are unequally affecting those in the lower power strata of our societies. So the goal is to decrease the disparities in the COVID-19 case fatality rates, which disproportionately affect vulnerable populations. Essentially, social distancing is a privilege. Not everyone could social distance. Think about multi-generations living in a small house. How could they social distance? And also there's inequities in testing due to lack of access. And so we have to consider the social environmental context. So one way to address the inequities is to do research to find out exactly what is happening what is the context and how could we change social policy in order to address these inequities. And one way is to do what's called implementation research, the promise and challenges in addressing inequities. So in this past year, this slide shows several headlines of research addressing inequities that's happening during the pandemic. So addressing health inequities through implementation research, there are three different paradigms. One paradigm is to use existing data or obtain new data to understand what drives disparities and how they can be overcome. The second paradigm is to include populations with health inequities in new implementation research. Or the third paradigm is to focus exclusively on populations experiencing inequities. So how can implementation research help address inequities? So there are four things to think about. Implementation research provides a framework to identify the causes of gaps in care and outcomes. The research could help us understand contextual factors which impact access, uptake, and quality. And then once we have identified the causes and understand the specific contextual factors, that could be transformed into actionable knowledge, and then implementation research could help adapt and scale up interventions that have been proven successful in other settings. So advancing health disparities research within the healthcare system needs a conceptual framework, which is shown in this slide here. So we see that implementation research could help detect, essentially define health disparities, define who are the vulnerable groups, measure disparities in vulnerable populations. And then once we define who are the vulnerable groups, we could now understand the contextual factors, identify determinants of health disparities at the following level: the patient, provider, clinical outcome, and the healthcare system. And then once we have all this information, then we could develop policies to help reduce the disparities. We could intervene, evaluate, translate, and change policy. So these are the three phases of disparities research agenda. So let me, so in terms of identifying, this slide shows a list of all the potential vulnerable groups: women, older persons, adolescents, persons with disabilities, where's my slide? What happened? Oh, I see. Migrants, minorities. So we could identify the vulnerable groups. And then in terms of understanding, we could understand the origins of the health and healthcare disparities at all the different levels, patient factors, the clinical encounter, provider factors, and also the healthcare system factors. Essentially, the healthcare system responds to the pandemic, but there could be inequities caused by the healthcare system response to the pandemics, which needs to be changed. So in terms of understanding, we need to understand through research the contextual factors in the external environment in individuals, families, and health systems. An example that's happening now with the vaccine distribution, a title from a recent editorial, Equity Left Behind. Essentially, we have all these policies and how to distribute the vaccine. However, we have to understand why vulnerable groups are left behind. They don't have the means to access the vaccine in their society. So, and then once we detect, understand, now we could institute policy to reduce the inequities, and essentially evidence-based intervention. Can the program be adopted? Can providers deliver it with fidelity? Will the program actually reach the intended populations, and will organization sustain it over time? So the last thing I want to talk about with doing implementation research is the issue of building partnerships for health equity. And what I want to talk about is community engagement. This slide shows the community engagement continuum. And we have community outreach, consult, involvement, collaborate, but we want to reach to the higher level of community engagement across this continuum. We don't want to merely consult with the community. We want to have shared leadership with the community. And essentially, this slide shows a recent call for applications. My apology for showing a call for proposals after the end date of February 19th. But what I want to demonstrate is that this TDR WHO call for proposals is to identify good practices in engaging communities in research for implementation and in social innovation in low and middle income countries. And well, one of the topics was mapping of ethics review committee practices in relationship to the engagement of communities in research to enhance healthcare delivery. So essentially, what is the role of ethics committee in ensuring that there is adequate community engagement? I want to bring up some thoughts from Jim Lavery, who also believes that we should have community engagement, but the partnerships with community needs to be fair. Fair partnership is a determinant of effectiveness of global health campaigns and implications for research ethics. Jim has a very interesting point of view. He says that the dominant paradigm in research ethics is not sufficient for engaging communities. His concern is with the fact that the dominant bioethics or the dominant research ethics paradigm is too focused on protections for participants, and it's too individualized, exclusive focus on individual research partnerships. He would like to see us move to a newer paradigm for research ethics that includes the dominant paradigm, okay, but also includes stakeholder engagement, and in addition, fairness in research partnerships with the stakeholder engagement. And let me just borrow one or two more minutes of my time to end up. So essentially, he wants to focus on who are the stakeholders, what are the interests of the stakeholders, and how do we engage with the stakeholder. And he says that we need to borrow the stakeholder theory from businesses. Who are the stakeholders? And the stakeholder theory is about how to create value for our stakeholders. And value is determined according to the specific interests of each stakeholder. So, and then what is fairness in research partnership? And he has this research fairness initiative filling a critical gap in global research ethics. Essentially, fair partnerships recognizes that partnerships are ethically significant. There is a challenge for realizing the full ethical potential of fair partnership lies in how to design fair partnership models and implementation strategy for their use. And so fair partnerships are about establishing fair terms of cooperation and collaboration between and among programs and stakeholders pursuing joint ventures or mutual goals. So the dominant paradigm of research ethics is silent on the importance of fairness as an ethical goal for the principal vehicle, meaning partnerships, through which global health research and implementation programs are delivered. And so we have stakeholder engagement and organizational learning, fair partnership, broker design, and knowledge co-production. And let me end on a somewhat personal note. and tell you that we have this WH grant for doing implementation research in Myanmar. Unfortunately, due to circumstances that you all know about Myanmar, this grant is on hold, but this grant that we obtained was to strengthen community engagement to ensure effective and equitable implementation of strategies involving social vulnerable populations in response to COVID-19 in Myanmar. A qualitative study. Essentially, the goal was to develop community-based planning and implementation strategies to enhance communication of mitigation strategies towards viral transmission and improve equity and access to government provision of COVID-19 services. Our approach was to do interviews of key informants of community-based organization and civil societies, local villages, and religious leaders and international NGOs to discover how to optimize current interventions and to discover new approaches to enhancing or decreasing, mitigating health inequities, and also to approach members of vulnerable groups to uncover their needs and unintended consequences of COVID-19. And I hope one day we could follow through with this type of implementation research in Myanmar. So with that, let me say thank you very much for your attention.
Thank you so much, Harry. I knew that your talk would be fabulous, but it really enhanced our perspective. So thank you very much for this speech. There is one question in the Q&A section. Would you like to answer it now, or would you like to answer it in the discussions part?
Oh, well, I'll take it now.
Okay. Okay, so the question says, how can founders ensure inclusion of poor communities in implementation science programs when reviewers are mostly guided by high-income countries' guidelines?
So repeat that one more time.
Sure. How can founders ensure inclusion of poor communities in implementation science programs when reviewers are mostly guided by high-income countries' guidelines?
Oh, okay. Well, that's an excellent question. Well, that should not be the case. The reviewers should not be mainly from high-income countries. There needs to be obviously an equal representation of people from high and low income countries. That has always been a problem in the past. For example, when devising international guidelines for research ethics. And so I guess my question is, are we sure that reviewers are mainly from high-income countries? Let me throw back the question to the person who asked the question, but maybe we could discuss that more during the open Q&A.
Yeah.
Thank you.
Yeah, that would be great.
Okay, great. Thank you.
Thank you so much, Harry.
Okay,
Thank you.
Let me stop sharing my screen.
All right.
How do I?
So now we'll proceed to to Morenike Apang's presentation. She currently works as a clinical research professor with the Obafemi Awolowo University, iLife, Nigeria. She has vast experience in conducting multi-country and multi-site research and engaged with policy development at the national, regional, and international levels. She discusses and writes about bioethics from the lens of a community advocate. Morenike, thank you very much for joining us today. Aaaq will help you to put your slides on. So I think she's working on that now.
Yeah.
And yeah.
Yeah, thank you very much. Yes. I'm also going to, ask, I just put on my video so that everybody knows that it's not a goat speaking. Otherwise, I'm going to switch off because of my bandwidth. And I'm also depending on the organizers to help me move the slides. Also, in a bit to address my bandwidth so that I don't go off. Thank you very much. So I'm going to, now you know it's not a goat, so I'm going to put out the, so I'll wait for my slide to come on. Thank you very much.
There we are. Go to the first slide.
Yeah. Could you please guide our students while you are changing your slides, please?
Yes, I'm going to, first of all, you'll have to put this on full screen. It's not on full screen yet. And when I want to move to the next slide, I would give the prompter next slide. Would that be okay? So I'm still on the first slide. Let's go back to the beginning. Thank you. So yes, once again, I think Henry's session was really brilliant, and it's a segue into exactly what I want to talk about in terms of ethical challenges faced in Nigeria during the COVID-19 pandemic. I'm going to speak on many issues that Henry raised and how that reflects in ethical concerns with the COVID-19 response. Next slide, please. Over the next 20 minutes or thereabout, next slide. Thank you. I shall be discussing the topic, referencing quotes from Michael Marmot's publication in The Lancet. He published an excellent piece of paper. I'll ask every person here to please refer to and read. I'll talk about that shortly. He published it on May 2nd, 2020. I will be reflecting on those quotes using the Nigerian lens. I would also discuss how some global ethics and moral issues affect Nigeria, and thereafter I'll summarize my reflection and conclude. Next slide, please. So the main message that Michael made in his paper titled Society and the Slow Burn of Inequality is how the offshoot of inequality gives rise to distrust. And I quote, when we conduct a post-mortem of this pandemic, or we take a stock phrase, knowing that this is not just a stock phrase, but more of a metaphor, we'll probably find that the same hostility to government that routinely undermines the effort to help Americans in need played a critical role in slowing an effective response to the current crisis. I think for me, when I reflect on this quote through the Nigerian lens, it's so easy to substitute the word Americans with Nigeria, and the quote will perfectly reflect the status of affairs in Nigeria also. Next slide, please. The next slide shows the publication by, the headline of the publication by Isabel et al., with the title Political Distrust and the Spread of COVID-19 in Nigeria. That title perfectly captures how the significant variable that have been left uncaptured in many discussions about COVID-19 containment. Whereas this very variable plays a significant role in delaying emergency response in Nigeria for many years. And if anyone has to recall, the best example that reflects the impact of people's distrust for government has been the long battle that the country undertook with its polio epidemic control. When polio became a disease of medical textbook artifacts in many countries around the world, Nigeria, along with Niger, were the only two countries in the world that were still battling with polio. Polio eradication only happened when community engagement became central and community decided to own the response rather than the government itself owning the response. And the role of politics and mistrust also reflected in Ebola epidemic and its current ongoing epidemic in Republic of Congo. And Richardson et al. In their 2019 paper cited Ebola and the narrative of mistrust, wrote clearly and said that the geographically broad and historically deep power relationship has contributed to the Ebola outbreak in the Republic of Congo. But this lack of trust has been left out of the domain of valid public health discourse, including research. And my colleague and I also highlighted this in our publication. Next slide, please. Our publication titled History, Culture, and Social Norms, Implication for Ebola Drug and Vaccine Clinical Trials, which we published in 2016, discussed the existing social and political tensions that undermine the cooperation required for effective public health response in the West African Ebola outbreak. Like it was then, health workers in Nigeria also went on strike during the COVID-19 pandemic. For the same reasons, healthcare workers went on strike during the Ebola pandemic. They were denied their hazard allowance. There was no PPE or personal protective equipment available. A significant number of doctors got infected and some died. In a country where one doctor serves over 4,000 persons, where 12 Nigerians are employed outside the country every week, that means they migrate. And even during the COVID pandemic, there was an exodus of doctors to foreign lands. The death of a single doctor is a major health crisis. Doctors in Nigeria had to wade through the ethical dilemma of obvious risk and danger. No government health insurance cover, and I mean no government health insurance cover for any health personnel in the country working in the public system. A pandemic that take care of, and the constant risk they pose to their family and friends. Having doctors manage a pandemic in a precarious healthcare system is one of a major ethical dilemma that I think we have and is continuously being faced during this pandemic. Next slide, please. There was a glimmer of hope when the rich also came down with COVID-19 and had to get treated in the public hospitals. Like Mammoth wrote, Nigerians felt COVID-19 was a great equalizer, as the lockdown made it impossible for the rich to go out of the country to seek health care. I am a medical health personnel, and I, along with my colleagues, felt that the rich will finally see the plight of the health system and respond. The rich did see, but what then happened was that the private hospitals got licensed to start treating COVID infection so that they could take care of the rich. And in this clinic, you have to pay an equivalent of about £10,000 to get care. And this you have to pay upfront. So once again, the pandemic created a gradient of care that forced a divide to be drawn between the rich and the poor. Next slide, please. That line was quite evident during the lockdown. And like Michael wrote, that once lockdown went into place, it exposed the fault lines in society. Those who could work from home and those who could not. Those who could retreat to holiday homes and those who had to stay in crowded flats. Those with income reserved and those who could not afford to buy food. Those in a position to offer home education to their children and those that were not so fortunate or well equipped. In effect, the lockdown had partly shifted the epidemic risk to the underprivileged. In Nigeria, the underprivileged university students spent 9 months at home without formal education access, while the kids of the rich, who are schooling in high-income countries or private universities continue their education. Those in public school now have to struggle with unstable internet, unstable electricity supply, online schooling with little or no support, to say the least. Once again, driving an edge between rich and poor as a result of the pandemic. Next slide, please. And yes, citizens continue to disbelieve that there's a pandemic. I mean, Once again, I recommend that you read the full text. And this is driven home by the ways our government has responded to the epidemic. Citizens wonder why huge sums of money go to address COVID-19 when we have lived for ages with other epidemics: HIV, TB, malaria, onchocerciasis, Lassa fever, cholera, dengue fever, and a myriad of others that have lasted for years, causing more death than COVID-19 had ever caused. But there was never an urgent response. Currently, my country has received COVID vaccines, 1 million doses, and the country is going to spend 10.3 trillion naira to move around the vaccines to serve 1 million of its 215 million population. This is an unbelievable astronomical budget in a country where the 10.3 million naira to move around COVID vaccine is more than the national health budget, also more than the national education budget. And all of a sudden, this money comes out from the coffers of the government. But the crisis of trust further gets entrenched even through the COVID pandemic. Next slide, please. At this junction, I would like to discuss a little about ethics and morals before I summarize and conclude. I will highlight this with an analysis I conducted in November 2020, where I highlighted that though West Africa, the region that houses Nigeria, only hosts 3% of the African pandemic population, 7 of the 17 countries in Africa that has case fatality higher than the global rate of 2.3% are in West Africa. And those countries are highlighted in red. In effect, although the COVID-19 pandemic seemingly caused fewer cases in Africa, Nigeria inclusive, the impact was actually worse. Next slide, please. And mathematical modeling indicates that large service destruction in Nigeria has the potential to leave over 6 million children without oral antibiotics for pneumonia, almost 5 million children without the DPT vaccination, more than 700,000 women without access to facility-based delivery, and more than 2 million fewer women receiving family planning. In effect, as a result of disruption because of COVID-19, child mortality in Nigeria will increase by 18%, and maternal mortality also by 9% in 2021. Next slide, please. So for me, I think COVID-19 impacts in Nigeria has resulted not only in an ethical dilemma, and I'll discuss some of this ethical dilemma, or very few, or concrete ethical dilemmas that we see in Nigeria, but it also raises the issue of moral dilemma. And one of the big moral dilemmas that we're dealing with right now globally with impact in Nigeria is about COVID-19 distribution. That the lopsided, should that be lopsided to where COVID-19 incidence is highest or where the impact is worse? And I'd like to plug the next slide to make my case at this time. Next slide, please. You see, when we're looking at the COVID vaccine access around the world, look at Canada, UK, EU, Australia, and US. These countries currently have over-ordered for COVID-19 vaccines at the minimum for a quantity that is double the size of its population. At the minimum, Canada has 5 times that is needed for its population. But when you look at African Union, where Nigeria belongs, only 38% of the African population is covered by vaccine access currently. Next slide. In effect, by the end of 2021, Canada, US, the EU, the entire citizens would have been covered by vaccine access. Africa, where Nigeria belongs, we have to wait till as far as 2023 for us to have vaccine, for the whole country to have vaccine access. Next slide, please. And what is the big concern here? I think for us in Africa, and Nigeria inclusive, is the concern around trip waivers. Trip treat is supposed to be waived at pandemic times like this. At the time, this is a time when treat should be waived. But here we see high-income countries like Canada, US, Australia, Brazil, standing against the trip waiver. And therefore, we have a crisis of confidence also, where African starts to think that the COVID itself is an entire ox for the rich to continue to benefit. Next slide. So when I ask the issue of ethics dilemmas and moral dilemmas, there are questions that come to mind. And sadly, I'm dropping those questions with you. I am not answering those questions. For one, what is the obligation of healthcare workers to provide care during a pandemic when there's limited access to protection to reduce their risk of nosocomial infections? How does ethics respond to this kind of challenge? And for Nigeria especially, how do criminalized populations who have otherwise not accessed healthcare services before the pandemic due to fear of arrest now access essential health services during the pandemic? In this case, I'm talking about Nigeria being one of the 76 countries in the world that criminalizes same-sex relationship. And there's evidence in the literature, evidence all over that shows that this criminalization of same-sex relationship has limited access to services by those sexual minorities, resulting in increased death, especially around HIV. Now that services in terms of COVID-19 are limited largely to public health services, how do these persons then go into these facilities to access essential COVID-19 related care? There is currently no measure about this impact with clarity for people of us to understand the ethical implications and how to make a difference. Next slide, please. So I think in Michael's word, I also want to agree very strongly with him that the COVID-19 recovery plan should focus on reduction in child poverty, funding of services to improve outcomes for children, funding for education, improving working conditions, ensuring that everyone has at least a minimum income to lead a healthy life, and creating health and sustainable environments in which to live and work, and creating the conditions for people to pursue healthy behaviors. Next slide, please. So I would summarize by reflecting on Michael's words that there is a need to recognize the role of the state and the importance of policy. It's also very important to respond in an equitable way to the climate crisis in order to slow down the injustice of health inequalities, which is raising ethical issues at this time. And my point here is that these are not philosophies. These are things that cannot happen. New Zealand is an example that has put people's well-being as the center of its policy. It's not fluke, it's real. And that well-being approach for their policy implementation enable people to have the capacity they need to live lives of purpose, life of balance, and life of meaning. And we saw how that played out very well during the epidemic and during the pandemic. New Zealand's response is exceptionally exemplary. Next slide, please. In conclusion, once again, through Michael's word and in Michael's lens, the COVID-19 pandemic should never be treated as a waste. It's a good crisis and a lot can come out of it. As we emerge out of the COVID-19 pandemic, it is important to look forward to the kind of society that we want. On that note, I would like to say thank you. And that's my final slide. Next slide. Thanks for listening. And over to the thank you.
Thank you so much, Morenike, for this presentation. Michael Marmo was my compass during my PhD while I was writing my PhD dissertation. So I mean, your presentation was really great, and I think you met at many points with Professor Silverman's presentation about the privilege of social distancing or taking or obeying the public health measures during the pandemics and the deep inequalities it brings together. And the two questions that you raise, the first one about the moral obligation of physicians to serve, although they don't have adequate PPEs, and the access of vulnerable and disadvantaged populations to healthcare, the people who didn't have adequate access to healthcare in normal times is worsened during the pandemics and in any other public health emergency. So thank you once more for this presentation. And now I don't see any questions in the Q&A yet. By the way, all the participants can type in their questions in the Q&A. Our panelists may answer you by typing in the answer, or they can answer during the discussion, or they would prefer, if they prefer, they can answer after the presentation as well. So with your permission, we'll move to the next speaker, who is Farah Asif. She's a clinical research administrator since 2006 to date in Pakistan. She also got a qualification as European Fellowship in Research Ethics. She is a member of Advisory Committee for the Academic and Research Programs of the Faculty of Allied Sciences in Women University. Thank you very much for joining us today, Farah. The floor is yours.
Thank you, Elif. I hope you can all hear me well.
Yeah, we can hear you. We hear you perfect.
Great. Thank you so much for this opportunity. It would be great is it possible for you to share my slides?
Yeah, sure. So
that would be great. Good morning or good afternoon, everyone. Thank you so much for making me part of this event. Great presentations so far. The concept or the difference between equity and equality was never clearer, and I would thank Professor Silverman for his nice presentation. And thank you so much for your nice thoughts, Morenaik. Thank you so much for this. So today I would talk about research ethics review during COVID-19 pandemic in Pakistan. So can we move to the next slide, please? Is it possible to move to the next slide, please? Okay. So if possible,
I'm moving between the slides. Can you see the second one?
Yes, I can see this.
Yes,
but
we can.
Yeah, you want to
slideshow mode.
You want this one?
Slide 2. So my country is Pakistan, and it is low income country with a population of over 220 million people. And in recent years, we have seen a significant rise in research output from Pakistan. I think I cannot see the slides yet. So if it is possible.
Okay, I'm stopping sharing, and I will try it again.
Okay, thank you.
Can you see it now?
Yes, perfect. Thank you so much. And in the pictures, you can see my institute. It is Shaukat Khanna Memorial Cancer Hospital and Research Center. It is a cancer hospital situated in Lahore in Pakistan. The inspiration to build the hospital came from the suffering of one individual named Shaukat Khanna, who is the mother of former cricket captain of Pakistan, Imran Khan, and he's now the Prime Minister of Pakistan as well. His personal experience of dealing with cancer in a loved one convinced him of the need for the state-of-the-art cancer center with access to everyone, including those who could not otherwise afford the expensive care. Through a cancer hospital, but capacity for all types of relevant research offers a potential for change that is untapped for countries like us, and we wish to be instrument for the kind of change. Can we move to the next slide, please? So today, I would be talking about the research ethics review in Pakistan during COVID-19 pandemic. And I would like to take you through the normal process, how ethics review process works in Pakistan. And then we will talk about how ethics review process was evolved during COVID-19 pandemic. And of course, this was not easy. There were challenges. And following the challenges, I would like to talk about the way forward. If possible.
Actually, I'm changing the slides, but I think I have a problem with my computer. So
so that should
be trying to help you right now. I'm sorry for this. Okay, I'm stopping sharing and we will share it again.
So that should be perfectly fine. If we cannot run the slideshow, I can still continue. Thank you so much for helping me with this.
We will run it. We will run
okay,
it.
Great. Thank you. So in Pakistan, the birth of ethics and ethics review dates back to 2002 and 2003. This was the time when National Bioethics Committee of Pakistan was founded. This was the time when there was a global development of ethics review committees worldwide. Following this, there were many institutes in Pakistan. They established their institutional-based ethics committees because they identified the need of having this. And of course, one of the reasons was that they needed to qualify for funding opportunities, and for that, they needed to have some mechanism of carrying out ethics review within their institution. So that could be one way, that could be one reason why during that period, ethics committees were developing in a very large number in Pakistan. Though that was the time when the mandate, the processes, the guidelines, the regulations, as well as the funding was not fully sorted. National Bioethics Committee of Pakistan is the main official body to uphold the bioethical principles in all sectors of health research in the country. All research studies, they require a prior approval from the local ethics committees within the institutes. And the national level projects, as well as interventional global clinical trials, need approval from national bioethics committees. And these projects would then go to Drug Regulatory Authority of Pakistan for review. And all these bodies, they complete their ethics review independently. They do not commonly coordinate with each other. So this is how ethics review process usually work. All committees, they carry out the ethics review process independently, and there are no mechanisms of common interaction between the local ethics committees as well as ethics committees within different institutes, as well as ethics committees and the drug regulatory authorities. So it would be great if we could move to the next slide. Okay, keep going. Next slide, please. And next slide. Okay. So can we go back? Thank you so much. Thank you. So when COVID-19 hit us, that was not the first emergency or the disaster that we witnessed. There were previous emergencies as well as natural disasters in Pakistan that we had witnessed. In 2005, there was earthquake, and in 2010, there were floods, which resulted in a national level emergency and huge number of deaths as well as associated disasters. During that time, we have witnessed a surge in research activities. And it was already identified that whenever there is an emergency, there is a need to review these research studies with competency as well as with the speed. So when COVID-19 reached us, it was not our first experience of having the emergency. But there is little evidence that we have a national level agreed upon procedures that were already there to help us during the COVID-19 emergencies. Though there were searches, there were ethics reviews, and these were done with the speed as well as with the commitment. But it seems that we never developed, we never prepared for the next emergency, or we never developed a national level agreed upon procedure. So when COVID-19 hit us, if I may say so, we were not very well prepared again. During COVID-19 pandemic, and having lived it for a year or so, we have witnessed that international as well as national guidelines, these have developed. And this has been steering us, the ethics review process, as well as the oversight process in the right direction. And this was the case with Pakistan as well. National Bioethics Committee of Pakistan, they developed their guidance, primarily describing how they would be reviewing their COVID-19 research in a rapid turnover mechanism, so that they would ensure that any research that is related to COVID-19 that would be reviewed and approved within 72 hours. They would review it within 72 hours, and they would give a 24-hour period window to investigators to respond back. And this was very interesting because National Bioethics Committee, they kept their commitment. They were providing their first review within 72 hours. But in many cases, it was seen that the investigators, they were not able to reciprocate by providing their responses within the defined time frame. That partly reflects that they might be busy with dealing with COVID-19, as well as they were not very well prepared, because at that time there was surge in research, and we witnessed there were studies which were small studies, which were single-centered studies with insufficient power. There were collaborations which were just there, like opportunistic collaborations. There were many studies proposed by investigators who had no experience of doing research during emergencies. So that were the challenges. We would talk about the challenges again, but I would like to show you the mechanism that the National Bioethics Committee has devised to respond to the need of speedy and competent ethics review. And they tried to facilitate the researchers by providing a rapid turnover system. However, whenever they were providing these services, it is important to mention that they were doing all of this work. They were keeping their commitment. They were not getting paid for doing this work. They were meeting frequently. Quite often, then they would regularly meet. But they were provided with limited secretarial support. They had no funding. There was a time then when they had no funding to have a paid Zoom account even. They were using the unpaid Zoom account that allows you to have Zoom meeting for a limited time. So, but they kept on their commitment and they were providing these reviews. But of course, as a consequence, they were overwhelmed. They were overwhelmed with the workload. They were overwhelmed with the pressure. It seemed that there was an obligation to review the studies fast, and there was an obligation and pressure to approve these studies fast, because it seemed at that time that this is the way. A speedy ethics review and regulatory review is the way to bring a speedy relief to the public or your communities. So they were dealing with many pressures. And at the same time, they were dealing with the studies where science was not valid. So this made their job rather difficult. If you could move to the next slide, please. So these were the challenges which were unique to COVID-19 pandemic. However, there were challenges, inherent challenges of ethics review framework in Pakistan. In Pakistan, as I informed earlier, there are no formal mechanisms to interact among IRBs, local ethics committees, communities. There are no mechanisms for community engagement. The local ethics committees, there is no registry for ethics committees, which would mean that we cannot know where are the ethics committee, what is their number, what are their competency levels. There is no process of registration or accreditation. So they would continue to work in an unregulated manner. That would mean that we cannot comment about their competency levels, as well as they would have adopted their own procedures, operations, and it is hard to comment about those procedures. A majority of IRB membership remains without any formal training for the work. It is for the reason that the training opportunities for ethics are few. These are not readily available. These are not, there are no incentives to take up career in research ethics. It is like an uncharted territory. The progression becomes difficult because there is no career progression level. In this situation, it is hard to keep up your commitment for research ethics. There were external pressures, as we talked earlier as well, to influence the decisions of the ethics committees. There were issues with having transparent and robust mechanisms of conflict of interest management within the board leaderships. There were inconsistent applications of review requirements that all contribute in undermining the reliability of the review process. Some of the most significant threats to independent and uninfluenced functioning of such boards arise from the institutional leadership itself. Because we may call that ethics committees, they are independent bodies, but if they are working within their institutes, they would have some hierarchical relationships. In addition, there are national level guidelines, regulations, and the training resources. They are all limited. So this is the situation which is during the normal times. And of course, this affected us most during the pandemic. And the question for us was that what we have learned from the previous emergencies that we have learned. And there is little evidence that we were better prepared to carry out ethics review. Can we move to the next slide, please? When there was COVID-19, there was disruption of normal meetings. Of course, all of us have adapted to new meeting formats, but the institutions as well as ethics committees, they were not equipped, they were not trained, they were under-resourced to do these adaptations. The pressure to accelerate the review of COVID-19 related research protocols has only added and highlighted existing challenges for Pakistan IRBs and the national ethics review systems. The IRBs and even the NBCs saw a large increase in workload as well as an increase in expectation that threatened to overwhelm their capacity and lead to burnout of many members. So there have been reported instances of insufficient and even questionable IRB review practices during COVID-19 as well as in other normal times. Can we move to the next slide? So now we have the question, what is the way forward in this situation? So this has been identified that we need to initiate a serious national level dialogue. We need to find a common way forward, how to regulate research, while we do not over-regulate research, but regulate research in a way that is important for the integrity of research, for the scientific validity of research, as well as to build the trust of our communities in research. So, of course, we need comprehensive guidelines. In Pakistan, we have identified that there is a need for legislation as well. We need to have a registry of ethics committees, as well as we need to have mechanism for their accreditation, because that is the mechanism to ensure that ethics committees, which are charged with the duty of reviewing research during emergencies, they are competent to do that. And if they are not, we can find alternate ways to deal with this challenge. Of course, this can be, we need to have a good governance system that requires a centralized body, but of course with sufficient funding. We cannot sustain without funding. We cannot find any solutions without funding. That has been a challenge, that has been something that has limited the capacity of competent authorities in Pakistan. The reason why they have not done their job effectively or up to the expected level is because of the reason, because they never had resources to do that. And for this, funding is of course of fundamental importance. And we have learned that we need to find ways to have a synchronized approach to review research during pandemics, during emergencies. We need to find ways to talk to each other, to learn from each other, to share experiences. And it would be efficient if local ethics committees, national level ethics committee, as well as the regulatory authorities, if we find synergies that would be efficient, that would lead to less frustration of researchers who are dealing with COVID-19 as well and who are trying to do research. It would lighten their burden of processing multiple reviews, and all the review requirements may vary, their submission requirements may vary, their criteria may vary. So this is important. This would increase the trust of researchers to the ethics committees. And finally, it is so evident, it has been established that during emergencies, ethics committees, they have a bigger role. They have to play a role in trust building as well. So this would only be possible if ethics committees can do their job in a way to earn the trust of the researchers as well as the communities. And with this, I would end my presentation. Thank you so much. Thank you.
Thank you so much, Farah. This was a great presentation, especially focusing on ethics review process, which I think we all share the same faith for not being ready for the pandemics and how to handle the ethics review problems during the pandemics. None of us was ready for that, although we went through some public health emergencies before pandemics or public health emergencies like earthquakes and so on and so forth. So none of us was ready for this. And let me quote from the question of an anonymous attendee who typed in a question and saying that we are talking about being ready since COVID-19 started. So exactly what were the ethical precautions that could be taken against pandemic, especially for developing countries? Well, in fact, we should be prepared before COVID-19 emerged, so we don't get ready when the pandemic starts. It should happen beforehand. And not only for the developing countries, the pandemic showed that not only the underdeveloped countries or developing countries, but all humanity was not ready for the ethical issues that were raised by this pandemic. And thank you very much for your presentation on the ethics review committees and the challenges they are facing during the pandemic. And especially the last two slides were really very, I think, involved really important issues that we all have to think and discuss on. So thank you once more, and let's proceed to Francis Crowley, who has been connecting ethics and science for patients and public health through policy development and directed project, and he also directed projects, ethics research methodology, research integrity, GCP and GDPR expert. He's an ethics advisor, ethics advisory board member, and a data protection officer on several European Commission funded projects. He is a steering committee member and participant in several European Commission funded projects. He's also leading the preparedness planning for clinical research during public health emergency group, which I am proud to be a part of. He's organizing great seminars that we all learn and discuss about ethical issues during the pandemics. So I'd like to pass the floor to Francis. Thank you very much for being with us today.
Well, thank you, Alif, and thank you for this really wonderful discussion. And so, I think so very interesting here. I have the very bad habit of, when I'm invited to give a presentation, to give a title about something I don't understand, and then think that I will figure it out when I actually do the presentation, but I don't think I figured it out this time. So let's not look at the title too much. So what I wanted to do was just for myself, mostly really, to reflect together with everyone here on this COVID-19 and what it means for us, and particularly what it means for ethics. And well, I've been working in the area of ethics for a long time, more than 30 years, I guess. And I have to say that I've never been really convinced about ethics. I always thought ethics was interesting because it helped us to get other places. For example, it helped us to do research, and research was important for public health. But the ethics was never as close to my heart as perhaps it should have been, or perhaps I didn't understand it as well. Now during COVID-19, I think I'm learning about ethics maybe for the first time. And I'm really think that it's something important. So my question that I had for myself today was really, well, wherefore ethics? And that means well, wherefore means really two things in English. We usually say it means why ethics, but it also means really where ethics, and where is ethics in our societies. And I think that's the question that I've been asking myself throughout my career. And I've always been interested in the topology of ethics in our society. And in particular, it seemed to me to be interesting to study ethics committees, IRBs, because they had taken a place that didn't exist before in society. It's very strange, but they created a place in society for themselves. It's very close to creatio ex nihilo, a creation out of nothing, because there was no place there. So how do you create a place that wasn't there? And if we look at how discourses go, conversations go, which is what our group has been engaged in a lot of just talking for the last year. If we look at how the topologies of discourses around COVID-19, I think we have seen science come to the fore in our society. It's quite amazing now how many people would be able to have a reasonable idea of what a clinical trial is, or even what a phase 3 clinical trial is, which we didn't have before, or how a vaccine is developed, or how a medicine is developed. So science has really come to the fore in our discourse, and it's become very important to us. And then science and politics seem to have united with one another in a certain sense. The politicians saying repeatedly, we need the science. Many countries, including Belgium and the United Kingdom and the US and many countries around the world, have put together, say, special committees of scientists to help guide the political decision-making during this pandemic. And of course, we've seen COVID-19 expressed throughout economics, in all of our social discourse and so forth. But do we see ethics being expressed so well? And my feeling is to say right now is ethics is still pretty much in the place it was before COVID-19. But I think we will see ethics moving up this list as we go forward. That's my guess. Maybe it's wrong, but it's just a thought. So COVID-19 as a public health emergency has a ubiquitous character. And one of the things we should say in regard to the anonymous question that Professor Asif just read is, one of the things about an emergency is, one of the characteristics of an emergency is you can never be prepared for it. You can never be fully prepared for it. And an emergency is something that, with this, COVID-19 is not just the result of a virus. It's not just a public health emergency. It impacts every facet of our lives. Every facet. It's amazing, huh? It changes our activities. And there's very few people in the world who could probably say today that it hasn't, in some fundamental way, changed their activities. And very importantly, and tremendously importantly, it disrupts how we interact with one another. It's disrupted our work situations. And I think there's probably no place in the country, including the Antarctic, where it hasn't interrupted work situations. It's invaded to a certain extent our neighborhoods and our communities, and it's changed the character of our neighborhoods and our communities. And I mean that with regard to me stepping outside of my front door into the community where I live here in Leuven, Belgium, and it is completely changed because of how we interact with our neighbors, how we interact with friends, how we interact with in our own families is dramatically changed because of COVID-19. And I think it's reflected also in our private moments. We cannot escape it. And we'll see a lot about this going forward here. So in 1 year's time, I think we are going to see fundamental changes or fundamental changes have taken place with regard to science. At a simple level, we can say, let's say, with regard to the sciences that deal with medicines, clinical trials, clinical trial methodology, I think we have seen a significant change in the use of, for example, pragmatic trials. Now we're seeing human challenge studies, which are not new. Neither pragmatic trials or human challenge studies are new, but they're being pushed to the fore. And they are coming more into, let's say, accepted and more normalized practices. We also see the relationship between RCTs, randomized controlled trials, and non-inferiority studies being looked at again. And we're seeing this, I think, for the first time since 1999, 2000, when we had another kind of global public health emergency with HIV/AIDS, where again, we have this enormous focus on randomized controlled trials, on placebo, and the whole question of placebo is going to start again. It's going to start again. It hasn't pushed itself to the fore yet, but placebo is going to come. And I mean, it's going to come in a month or less. It's going to be huge, I think. Now, we've seen it in social science studies. And the other thing that to say here is we're seeing a closer linkage now between social science studies and clinical trials. Now, it's not to say that link wasn't there before, but because COVID-19 has such an impact throughout our societies, because the public health impact is not only on, let's say, the sickness, the illness itself, but on how it expresses itself in society, that's there too. COVID-19 has had an enormous impact on data sharing and on data usage generally in public health. And this you can see many organizations, GoFair, Research Data Alliance, ECODA, all these new groups that are being put together to look at how we can share scientific data for COVID, but not just there, also in the background. Larger players like Google are also stepping into this area. So we're seeing a huge difference here. Publication practices are being radically changed. Now, neither the data sharing or the publication practices or even science communication, none of this is new, but it's pushed forward and becoming more focused on because of that. And how we can communicate science, and really science is, to a certain extent, it's communication. How we communicate that is also radically changing. The role of journals is changing. The role of open science is changing. We're asking ourselves questions about this. We're asking ourselves about the questions about ownership too in science. Who owns the science? You can see that completely if you want in Professor Silverman's and Dr. Marenga's presentation. They're there really in an evident way. Who owns this science and how do we decide who directs the science? And then we also see its impact on the media generally. I mean, honestly, I don't think there's been a news report in Belgium in the last year that has not, if not centered on COVID-19, at least had it as one of the major headlines. And for months and months, we had COVID-19 as the first headline here. And I think that's the case in many countries around the world as well. So how we gather information, how we exchange information in our societies, how we share information in our societies, that's been changing, of course, and quite a bit since internet came on, but it's changing now much more quickly, and COVID-19 is going to have its role in this. The question of what is trustworthy in communication, the question of what is trustworthy with regard to information, the question of, let's say, what is information and what is scientific evidence, that's becoming more and more difficult and more vague. And where do we go for information? Where are people looking for information for COVID-19? Are they taking that from their nightly newscast? Are they taking that from the front page of the newspapers that they trusted for the last 100 years? Or are they going other places to look for trustworthy information? And I don't mean just going to internet, but also are they going out on the street and saying to their neighbors, well, what about this vaccine? You know, is this a good vaccine, or should we be getting involved in this? So how are people doing this? How are people collecting this information? I think we've seen a new level of censorship in our societies that we've never seen before in many of our societies. Maybe censorship isn't the right word, maybe it is the right word, but there's certainly, limited things that you can say within certain platforms and within certain spheres of discourse. And then we have also this very new kind of strange relationship, and I think it's new, and COVID-19 has brought into this question, well, what is the relationship between our news and the science and the government? What's the difference now between science and government? To what extent is the government reflecting science? Or to what extent is science trying to reflect the government? So our religious discourse, our educational discourse, our social discourse, and our family discourse has changed. And I think if you change discourse, you change your society. So there is no going back to anything. There is no such thing as the lockdown ends and then we're back to where we were before. That has changed. How we gather, how we're allowed, or how we even decide ourselves to assemble. That's a major, major thing. Now we're talking about what is community. When we gather together, with whom we gather, and why we gather. All of this is changing. And if you want to understand what it means to be, what community means, or what it means to be a human being, it's very much has to do with how we gather and how we see ourselves gathering here. So what is the ethics of discourse? I cheated. I have to admit, I cheated. Most of you know I cheat. Sorry, my dog is cheating too. Professor Asif is preparing a paper, and I have a draft of it. So that's where I went. David Curry is preparing a paper, and he discussed it with me. So that's where I went. And I tried to understand what Professor Asif and David were saying. What is ethics, really? What is ethics about? So Asif says it's about values and principles. That's how I understood it. David said this is about integrity. That's how I understood it. I think it's something about truth, which is related to our convictions, which is certainly related to our values and principles. And I think it also has to do with something about courage. So it's a really important thing. There's something else too that's going to come forward. When we talk about ethics, we've tried to figure out really where ethics fits in our society. We've done that primarily, and Dr. Farah really showed this well, with ethics committees. We've given this designated place for ethics in our society. But somebody else in the questions asked today, well, what about ethics in a broader sense? What about ethics beyond just serving biomedical research? What about the ethics that's more prevalent or should be more prevalent in our society. Where do we put that? Where does that come from? And we haven't addressed that question yet. We know we see business ethics everywhere. We see companies setting up ethics committees. We see police setting up ethics committees. We see armies setting up ethics committees. Seems weird, but it's not weird in a way. I think what we have yet to do, and I think COVID is going to help us do this, and we have seen this in societies outside Western society, is we haven't asked the question properly yet. We haven't dared to ask the question, what is the relationship between ethics and religion? Because if we don't ask that question, and we're afraid to go down that road of that question, we won't be able to properly situate ethics. We are trying to situate ethics with regard to politics, with regard to science, with regard to law, with regard to medicine. Those are basic fundamental structures in every society. We also have to situate it with regard to religion. And that's a question that needs to come up, and COVID will ask it. So Professor Tamara from Kyrgyzstan, when we were writing a proposal for the WHO, we were sitting with a group of people in a Zoom meeting, the way we gather together, discussing this proposal. And what she said is, with regard to ethics, is that above all, we see an almost unexpected rise in ethics in our political, scientific, and even everyday discourse within our societies. It's unexpected and it's ill-prepared. And I think that's really what's the core is now. Ethics is being pushed to the fore. We heard it throughout all of this discourse here. We don't hear it so much from our politicians. We don't hear it so much from our scientists. You know, amazingly, there's or I forget the name of it. There's a group of funders and scientists that got together and want to put together a plan for rolling out vaccines and rolling out research during COVID-19. They're going to meet at the end of this month. There's not a word in there about ethics, right? If you look at Bill Gates, when Bill Gates started to get involved with philanthropy, his first idea was, we're going to take a ton of medicines, mostly vaccines, put them on an airplane and fly them into Africa. And we're going to do public health that way. He realized very quickly that doesn't work. So he said, okay, we have to do research. So they start to do research. They realized very quickly, you can't do research if you don't do ethics. EDCTP did the very same thing. Europe is going to get involved with the rest of the world in helping the rest of the world with research and medicines. So we'll set up the European and developing countries clinical trials partnership, which is really only between Europe and sub-Saharan Africa. And we'll do clinical trials. And that's what they did. They wrote calls for clinical trials. And suddenly they realized we have to do ethics, because we can't go into these countries if we don't do ethics. And by the way, the WHO was the same way. 20 years ago or 25 years ago, you know, ethics was deliberately excluded from the World Health Organization when it was set up. That's why SIOMS was set up. And then WHO realized, you know, it took until 2000 for them to realize, oh, we need to address ethics committees in order if we want to do the research. It took UNAIDS until 1998 to realize, or 1998 to realize we have to address ethics committees if we want to do research in these countries. So ethics is coming to the fore in our societies. And this is really interesting to see this in Kyrgyzstan. There's people saying there's no place for ethics in our society. But it's coming. COVID-19 is bringing it. And we're going to have to find that place. We're going to have to create that place. So just two challenges here. Are we able to provide an appropriate and well-defined place for ethics in our societal institutions? and in our shared discourse? Can we define that place? And can we do so? Because this was the challenge of science during COVID-19. Could science remain true to itself during COVID-19? And can ethics remain true to itself during COVID-19? Thank you.
Oh, thank you. Thank you, Francis, so much for this presentation. I always like to listen to you, and this presentation was really, really great. And the questions that you raised, I'm very much into those questions, and especially where is ethics in our societies, and where will ethics place be in our societies after COVID-19 pandemics? Is it going to have a greater place, or will it have other designated places like the research ethics committees, or are we going to forget all about this when we go through this pandemics and go to our normal state and be shocked again when we face with another public health emergency or a pandemic? So we'll see, but I think this depends on us, very much depends on us, the scientists, the ethics, the bioethicists, and the people who are involved in these discussions. I think we all have responsibilities to find the right place for ethics and scientific integrity after this disaster for the humanity. So thank you very much. There is one question from Professor Arda. She wrote it to the chat, and I would like to convey that question to you, if it is okay. All right. And before doing so, let me use this as a chance to speak very shortly about two people who are very dear to my heart. One of them is Professor Arda. She has been my teacher, my mentor, my guide since I started my journey in bioethics. And the second one is Dr. Munir from Boston Children's Hospital. He has been my mentor during my Faculty Fellowship. They're both here today, so I'd like to thank them both for coming and joining us. So the question is what we would think about the future global health governance bodies. We can remember Ebola virus disease of 2014 and 15 and the real problem of governance. So when we are observing and experiencing the governance problems relevant to COVID-19, what we would expect this sort of global health bodies, institutions in near future. And the question is also for Professor Silverman as well, and he can, Professor Silverman, you can step in and share your thoughts, of course.
Thank you. I'll go first. I think Professor Silverman will answer it much better than me. Firstly, I want to say any question that comes from Professor Arda will scare the life out of me. But I'll try to say something reasonable. You are right to, you are lucky to have Professor Arda as your mentor and guide. Nobody has moved the needle in bioethics more in Turkey, I believe, than Professor Arda has. Governance. Haven't we really been talking about governance the entire webinar? Isn't that where Professor Silverman started? Isn't that exactly what Professor Marenica discussed when she discussed communities? And isn't it also precisely what, in a very good way, Dr. Farah discussed when she talked about the ethics committees, the IRBs in Pakistan, how they're structured and how they work together? The question, I think, really of governance is about how we work together as a community, as that community being here in Leuven, or that community being Belgium, or that community being the larger world together, how we work together as a community. That's really about, it cannot be, and it would be a terrible thing if it was, simply from the top down. If you think about medicine, you think you want to be, and Professor Asif, you're a medical doctor, if you would think, when you're really thinking about medicine, you want to be as close to the patient as possible. And when you think about governance, you want to be as close to the people as possible. That's really what you want to do. So how we do ethics governance cannot happen at UNESCO or at the WHO, not by itself. They have a role to play, but the people outside your front door, they also have a role to play. And that's how we have to try to think about this, how we have to try to build this. But Professor Silverman will answer this better than me, please.
Okay, Francis, thanks for your faith in me. First, I'm having technical difficulties with my video, so you can't see me in live action. Instead, you're left with a picture of me from 20 years ago. And don't ask me why I keep this picture, but anyway, all I can say is that I think originally Asif wanted to show a picture of me from 40 years ago. So I don't know what my problem is, but anyway, so I've been, any question about governance is a very interesting question. And I've been thinking a lot about governance because I think it's something that is sometimes forgotten in the ethics discourse with all the other values we talk about, beneficence, autonomy, blah, blah, blah. And if we think about it, ethics, and I appreciate the list that Francis shared with us just a few moments ago. And it's really wide reaching, and governance is an important ethics value. And I don't think I could answer the question posed about governance because every different context will require a different governance system. For example, biobanks needs a specific governance structure, and ethics committees need a specific governance structure as well. But let me punt by saying that a governance structure, wait a second. Yes, right. I think now you see me live and keep me honest. So let me just simply say any governance structure has to, and this goes back to stakeholders, has to engage all the relevant stakeholders. And when that happens, I think the real purpose of governance is to ensure trust. And trust is something that I think that we shortchange what the meaning of trust is and what's the value of trust. Trust is necessary in order to have a transaction between individuals or between parties. And for me, that is, let me just end by saying that is the importance of having an adequate governance structure, is to ensure that there is trust between all the different stakeholders on that governance body. So let me just stop there, because to really delve into the concept of governance requires a separate webinar in and of itself. But thanks for the question.
Thank you so much, Professor Silverman. I took a note about the new seminar on governance. So All right, thank you so much. Now we are going to the Wales. Actually, this has been quite a journey today, a virtual journey, starting from Turkey and to the States, and then to Nigeria, to Pakistan, to Belgium, and now to Wales. Ryan, thank you very much. Thank you so much for your patience. We have kept you waiting, but I think you enjoyed the discussions as much as I did. So that might be a little excuse for our delay. Let me introduce Ryan. She's the lead in research and development, lead for NOAA's Aaaq Children's Hospital for Wales, and operational lead for the Children and Young Adults Research Unit, which is a clinical research facility which delivers early and late phase clinical trials for children up to 17 years old. She's now a PhD candidate at the Hillary Rodham Clinton School of Law, researching whether children have the right to benefit from scientific advancements and whether international human rights treaties give rise to a duty to develop medicines for their unmet medical needs. So Ryan, the floor is yours. Thank you very much for joining us today.
Let me just try and share my presentation. Okay, thank you very much. And thank you so much for the opportunity today, Alif. It's amazing to follow such great speakers and slightly intimidating too. You've heard who I am. I work in the Children's Hospital in Cardiff. It's the only children's hospital in Wales. The research unit was set up 3 years ago. Before that, we didn't have a facility in Wales for children to participate in clinical research. So my presentation today is going to concentrate on experiences within the UK, more particularly in Wales, because that's my experience base, and really ask whether the decisions that we've made on behalf of children have been evidence-based, evidence that's been generated through research, and if they haven't, whether or not states have a duty to conduct such research. I'm hoping some of this will link back to Prof. Silverman's presentation earlier as well on inequalities. So there have been numerous headlines in the UK relating to COVID-19 and children. We've seen the direct impact of the virus on them, and this is in particular relating to what the first case in April 2020 of what would become known as Pediatric Multi-System Inflammatory Syndrome, or PIMS-TS for short in the UK, or I believe in the US it's MISC. Some of the symptoms of this new syndrome overlap with Kawasaki disease and toxic shock syndrome, and can lead to children being hospitalized. What we've also seen a lot of is what has been termed the collateral damage of COVID on children, which includes the impact of school closures, the impact of lockdowns, school closures and child's education, school closures on the impact of children's networks, and mental and physical health. And also referring back to Prof's presentation earlier, I'm fully aware that some of these issues are likely to hit children differently depending on their socioeconomic status. Okay, so now I'm going to come through really to the decisions behind the headlines and ask really whether or not the decisions behind the headlines were evidence-based. So school closures happened for many, including children in the UK early on in the pandemic. And this was accompanied by lockdowns and orders to stay at home, and together with vulnerable children also being put into shielding. There was a reduction in health services, including routine appointments being delayed, and decision that impacted us quite significantly was this decision to close down many research studies to new recruits. We've also seen in the hospital the redeployment of some of our research staff, and our research space was also redeployed to another service without some of our nurses being sent to the adult wards. And then on top of that, we also saw a delay in COVID-related research for children. So are these evidence-based decisions? So first of all, looking at school closures, there have been numerous studies across the world looking at transmission of the virus in schools. Public Health England started the SCID study in June 2020, the study which was set to look at outbreaks of the virus in England and what part educational settings played in this. This was conducted when only a small number of children in the UK were back in school, and it took place when children from only certain years were allowed in, but a high percentage was still learning from home. This study was not recommissioned for the start of September 2020, when all children will be back in school. This followed a similar pattern in Wales, where we were unsuccessful in securing funding for any kind of schools transmission work, despite Welsh Government's technical advisory group recommending that further research of specific school cohorts was needed to answer unanswered questions on the balance of school closures. The UK can still not offer a definitive answer on the impact of school transmission on the virus. Only recently, a select committee proceedings at the UK Parliament in February, Professor Woolhouse of Edinburgh University suggested that it was safe to reopen schools to all those under the age of 16. Whilst countering that, John Edmonds, a member of the SAGE Advisory Committee to the UK government, commented that school openings could risk a resurgence in the virus. He also continued with a comment that without the younger population being yet vaccinated, the risks of further variants of the virus mutating was also a cause for concern. So here we still have a high level of uncertainty over the role that schools play. And Professor Russell Viner, who's the current president of the Royal College of Pediatrics and Child Health in the UK, has said of some of the research he did was that the point to the systematic review was that we just can't assume that anything we do will have an impact. We have to do it carefully. So then with this, I argue that we need to understand the whole impact of school closures and lockdowns on children, not just understand the impact of school closures on virus transmission. So we have seen numerous potential issues raised as a result of school closures and lockdown measures, which include the impact of more screen time and less exercise on long-term health of children, the impact of a decrease of education on long-term economic outcomes for children living through the COVID era. This can be seen in a very good WHO webinar on transmission. And yet, and we are yet to understand the impact of shielding on vulnerable populations. What we have seen in our hospital, and I understand this has been elsewhere too, although we don't have Wales specific data on admissions, is the increase in children being admitted due to mental health conditions during these periods. We've also seen a reduction in health services, and as I previously mentioned, in the first wave of the pandemic, the UK saw a reduction in routine services for children, including cancellation of non-urgent surgeries, and outpatient appointments were delayed. We saw delays in presentations to hospitals for children with temperatures after people were told to stay at home if they had a high temperature. And then also from a research perspective, as I said, we saw a total shutdown of non-COVID related research to new recruits. This reduced the opportunities for children to access interventions only available through trials. We had to turn away one potential participant who we knew would lose the opportunity to completely participate in the study because it was time sensitive. But also together with all of this individual issues is also the knock-on effect and delay to accessing new medicines coming to market because of studies being paused. We also, on top of this, saw a delay in commencing COVID-related research. Whilst we saw a surge in the UK of studies opening for adults, such as Recovery, a remap CAP, this was not true for paediatric studies. So early on in the pandemic, children were finding themselves in a position they could not access studies for conditions impacting on their daily lives, but also they were not included in the research response to the pandemic. Luckily, that's not to say that these haven't happened since. And as a site, we've been involved in a few studies, including the Pediatric arm of Recovery, which is looking at treatment options for children with both respiratory COVID, which we've seen is more likely to be in the adolescent population, and also PIMS-TS in the younger population. Also, as a site, we were involved in the Rapid-19 study looking at the seroprevalence of SARS-CoV-2 infection in healthy children. 1,000 of what they've termed COVID warriors, children across the UK, have given up to 3 lots of bloods over the course of 7 months, so that we can better understand the number of children who have had COVID, but also the symptoms. And now, of course, we've seen the vaccine trials commencing in the paediatric population, with the Oxford AstraZeneca study opening in the UK down to the age of 6. And I understand the paediatric investigation plans agreed by the European Medicines Agency. So there's numerous other studies in the pipeline. So do we have a duty to conduct research in the paediatric population? So I'm going to argue on the side of yes, but I'm going to base this on international human rights treaties. So the International Covenant on Economic, Social and Cultural Rights, and in particular Article 15.1b, states that state parties, of which the UK is one, must recognise the right of everyone to enjoy the benefits of scientific progress and its applications. To supplement this article, General Comment 25 was published in March 2020. The General Comments further sets out the obligations of the state regarding this Article 15.1b. Within this General Comment is what is termed an Aaaq Framework. And for those who have not come across it, this is a criteria for availability, accessibility, acceptability, and quality of rights. The frameworks are used a lot in human rights jurisprudence. Although we don't have time to go through the entire framework today, it clearly sets out what's expected of states. And in terms of this Article 15.1b, this includes that scientific progress should be taking place and is taking place, that the research infrastructure needed for it to take place is available, is acceptable, and it's of good quality. Also, importantly, that every person without discrimination should have equal access to participate in scientific advancement. This includes children. This opportunity is of great importance where it also impacts on the enjoyment of other rights, such as for children, the right to an education, which can be found under the United Nations Convention of the Rights of the Child, Article 28. So we've seen a mixed response in our hospital. We obviously have now seen an increase in COVID-related studies for children, and thankfully we are back up and running with our non-COVID studies. But the question now is, can we build back better for children? And if so, what will it need? What do we need to do in order to do that? So the situation with children at the moment is a continuation of the historic issues that children have faced in accessing research. The prevailing R&D models, especially with regards to medicines development, are ill prepared to provide for the child population. Small numbers of patients make it difficult for industry to see a return on their investment. However, the UNCRC, the world's most ratified human rights treaty, requires that states fulfill their obligations with regards to children's rights. The CRC has 4 core principles which must be considered when interpreting the rest of the convention. These include Article 2, non-discrimination, Article 3, best interests, Article 6, the right to survival and development, and Article 12, the right to have their views respected. In addition, Article 24 of the CRC concentrates on a child's rights to health, which includes General Comment 15, which sets out further what the right to health is. And it requests that children have access to appropriate prevention, health promotion, curative, rehabilitative, and palliative services. Research aids in the development of these services. And then we move on to Article 12 of the CRC, which requires that children are given the opportunity to have their views heard on matters affecting them. The Children's Commissioner in Wales has conducted a survey during the pandemic aiming to gather the views of children across Wales, but in general, children find it difficult to speak out about what they need. They rely upon adults to provide the necessary mechanisms to allow their voice, their opinions, their needs and concerns to be heard. That includes a mechanism to provide meaningful input into research to protect their rights during the pandemic. The current policy decisions made on behalf of children have impacted on numerous rights, including their right to health, right to an education, right to survival and development, and their right to participate in and benefit from scientific advancement. So can we learn and do better? At the start of this presentation, I questioned whether there was a duty to ensure that policy is based on evidence generated through research. I think we can use obligations from international treaties to build a case that state parties do have a duty, but I think we first need to build an environment which is more receptive to the idea that the needs of children can be better served through research. For years, we've considered it better to protect children from rather than through research. concept of autonomy and children's inability to give informed consent to participate in research being one major obstacle. However, many incidents have not helped, including in the UK, the 1996 CNEP trial, in which UK papers wrongly reported that babies were being used as guinea pigs. Unfortunately, you heard that term guinea pigs being used a lot around the vaccine research, COVID-19 vaccine research in children as well. However, by attempting to protect children from research, we've created an environment in which children are given medicines that are not appropriately tested for them, or where decisions are made to close schools without a robust evidence base. So I would argue that we need to combine a more receptive environment, such as that provided by, I've got on my slide, Joan Toronto's explanation of care ethics in her book, Moral Boundaries, with an understanding of issues for children and an understanding that can be provided using international treaties and jurisprudence as framework. So that Toronto discusses the 5 elements of ethics of care, being attentiveness, which includes the recognition of a need to be cared about, responsibility, which requires us to take care of the need, competence, that we are able to take care of the need, responsiveness, that we are able to respond to the needs of the care receiver, and finally, the integrity of care, that all 4 elements fit together as a whole, that we are able to identify and deal with the conflict that has been identified, and we conduct our obligations under the first 4 elements. So I would argue that in using care ethics framework and our framework provided by treaties, we can start to recognise that child health research is underfunded and under-prioritised, and that we have as a society have an obligation to respond to the need and work to find a solution that fulfills state obligations and respects the rights of children, the rights that children have. States, through ratification of treaties, have a legal obligation to respect, protect, and fulfil the human rights. This will obviously differ depending on the resource available to the state, but a starting point is a clear recognition that robust research is needed in the interests of children. So that's me. Just an acknowledgement to someone I've worked with, Rhian Croke, who I've worked with for the past 2 years now. We've been looking at a child's right to access medicine research, primarily in the Welsh context, where we've used both domestic and human rights treaties, and that's my email if anybody wanted to continue the conversation. So thank you.
Thank you so much, Ryan. A few weeks ago, I had the privilege to discuss the Aaaq framework with Ryan and Francis, and what Ryan is talking about to unite the law and international treaties with what's going on right now. I think it's really very important to increase the practicability of the regulations we have. I mean, instead of keeping them somewhere like very good words, but they don't have any implications in the real world, in real situations like pandemics, making them practical and implementable. I think that's really very important. Thank you very much, Ryan, for this presentation. Now, before opening the floor for discussion, I have two notes for the attendees. The first one is that we'll send you a form, and if you fill it and send it back to us, we can send you a certificate of attendance. And the second one is that we are also going to send you a very short questionnaire to hear your comments about this webinar, so that we will improve ourselves for the next meetings. And now the floor is open for discussion. If you raise hand, our hosts will see you, Dr. Banu, and she's going to give you the word to talk about your comments or ask your questions. Before doing so, I would kindly ask the panelists, the speakers, and Professor Aaaq, Dr. Munir, and Professor Arda, if she's still together with us. I think she had to leave. Okay, she's not. Yeah, she's here. I would like to ask if you would like to make any comments or if you would like to take the floor, and then we are going to open the discussion for our attendees.
Hi,
Hi, Dr. Munir. Hi.
Hi. I wanted to make one question, which I think the question of really the contribution of China and Russia in the distribution of vaccines to the low and middle income countries. Up to 50 countries, 500 doses have been distributed. And this has been actually recently acknowledged by the New York Times. And of course, it was initially not really emphasized, the role of how these, I mean, including Turkey, as you know, the vaccines in the CoronaVac and Sinovac in Turkey were widely distributed. So the question is really, here we have a huge discussion on equity, particularly with the Black Lives Matter movement in the United States. And yet, with regards to the global distribution of vaccines, really is life-saving. And there has been limited discussion and emphasis, particularly in EU as well as in North America. And I think Canada, for example, I think one of the presenters mentioned this, stockpiling vaccines or ordering vaccines excessively. So the question I have is really how politics potentially drove the ethics or the ethical sort of contributions of these countries. And yet in the US and EU, there was ethics, but the politics sort of lagged behind in terms of driving the ethics, the ethical obligations. So I just want the panel to comment on this paradox, because it's a very interesting paradox. And so I'm very curious about what you think about that. Thank you. And I'll take
Thank you so much.
the answer. I'll just mute my microphone. Thank you.
Thank you so much.
Yeah, this is Veronica. I think I'd like to give a response to that. Looking at COVID-19, the COVID vaccine, politics and ethics and nationalism. I think one of the things we would appreciate is the conflicting obligations within the context of ethics. When we look at, I mean, for many nations, when they ran and stockpiled the vaccines, it was based on a commitment to nationalism. And appreciating that drive to nationalism was instituted by political responses. Not laying any blame on anyone, but there was a Trump administration that could make a difference, that kept on re-emphasizing the need to care for your population. And what you found was a response to care for each person's population. Would you say that is an unethical response? No, I wouldn't say that. But I would think that when there is the political consciousness that stockpiling the vaccines would hurt other nations, there is an ethics care that was not responded to properly by the globe. But then who helped anybody understand how COVID vaccines access should be equitably distributed around the globe? There was nobody in that space helping people understand that you're overstockpiling with implications for the less developed countries. During this COVID pandemic, this was one epidemic that every country had to respond to their needs. This was an unusual epidemic where the resources of the high-income countries were not readily accessible to low-income countries. And low-income countries had to take on their responsibility, and many did it well. But that dynamics changed with the COVID-19, with the vaccines, where money had to come to play. So I don't think it's as easy and as simple as, politics overriding ethics. Even within the politics, I tell you that some would find ethical justification for the actions they did. But when the global picture started evolving and there was need to change things, I think then many political actions became unethical because of their non-willingness to make that redistribution happen. I think this for me is my own perspective at this time. Okay.
Thank you, Morinike. Are there any other comments?
Francis, maybe.
Yeah, please go ahead.
Is it okay? I want to respond
please
to
go ahead.
I thought that Professor Munir asked the question I should have asked, and in his question gave a better hint at the answer than I gave in 10 minutes of talking. But I wanted to ask too, Professor Morinike, about what she said here. She said that even though decisions that appear unethical, people can still find a response in ethics or give an ethical, what they consider to be an ethical response. So my question to Morinike, or to myself, let's say, is, should we expect that in ethics we're always good, that we always do good things using ethics or not? I mean, isn't ethics a human activity at the end of the day? Isn't it this a flawed activity? And how do we assist, which is, I think, the question that Professor Munir has asked and you're responding to, is then how do we insist that ethics, let's say, is ethical? I always, whenever I see somebody write an ethical review committee, I always change the grammar in English to an ethics review committee. And then I tell people, well, we have no idea if that committee is ethical or not. And let's not ask that question. That might be a dangerous question. But let's call it an ethics committee. And so, Morinike, should we expect in any area in our lives that we always have this kind of sense that we're always doing good, and not sometimes, even in ethics, doing bad?
Yeah, thanks, Francis. And I would argue that you would definitely know as well as audience here that that is a complex. And I also would respond that just as life and consequences, ethics and the definition of ethics also is informed by social, environmental, cultural values. And truly, is there a standard called ethics in any context? So I think it's complex. I think what is bad and good is defined by societies. We do know that, and that's what ethics is. I think also the context defines what is right and wrong, and we also will have to appreciate that. And that right and wrong also varies and differ within the same context by time. What might be right now, and like I did note, for me, that was what was right at one time definitely isn't right going forward. So it's complex, Francis. Thanks for joining it to me, but I'm also throwing it back to you, what your own perspective, as well as opening it up to panelists, what their own perspectives are in terms of Professor Munir's question. Thank you.
Thank you, Morinike. I see Professor Silverman unmuted. Please go ahead.
Yes, right. Very interesting question. And whenever I teach ethics to the medical students, I'm reminded of all the different ethical theories that we have, and is any one ethical theory more ethical than the other theory? So in terms of sharing vaccines, is it based on an ethics of care? Is it based on an ethics of mutual self-interest, meaning that we know that in order to really beat this pandemic, we need a global herd immunity? So we have what we could also call enlightened self-interest. Is that any less value than an ethics of care? And now we're bringing up an ethics of politics. Maybe that's an oxymoron, ethics of politics, but I'll put it out there. So which is more, which has a higher ethical value among those three? And that would be interesting to analyze. But let me get back to my previous comment about trust. Which ethics value, or which ethics stand generates the most trust. And maybe one could analyze it from that point of view. So one could say, if politics is driving ethics, well, then if that's what it takes to have the poorer countries involved with the vaccines, then so be it. Though, one has to be careful of what is driving the motives as well. And I'll leave it at that.
Thank you so much, Professor Silverman. If there are no other comments, I'd like to pass the floor to Nitsa. In fact, she asked the floor at the beginning of the meeting, but I couldn't do it because of the program. So I think she has some comments. And by the way, she's joining us from Brazil. Thank you so much for being together with us, Nitsa. And we can hear from you now.
Oh, thank you, Elif. Hi, everyone.
Hi.
I was here at the first beginning, but somehow I couldn't chat for all the comments you and Francis had on today. But I was thinking more about the linkage we cannot achieve between science, politics, social issues. So I'm kind of concerned about this linked. For sure, we have more understanding about research by now. As Francis said, everyone knows how to do a clinical trial, how to do a vaccine clinical trial, and so. But still, people cannot see how damaged would be. We have a world that have no all communities vaccinated. So if you have one community not vaccinated and not doing their best to save their lives, I mean, using masks, all the washing hands and social distancing and so on. If you have one place that is not well, you would have all the world in threatening. That's the first phrase of the WHO president at the first beginning of the pandemics. I believe that. So I think I don't know how would be the answer, how to link all those spheres and areas to make people understand that all the things are linked, economics, social, and so on. Thank you.
Thank you so much, Nisa. I think until we find the answer to how to find a moral ground that serves for science, politics, social issues, and health, it will be very difficult to answer the ethical issues and moral problems that arise during the public health emergencies. Thank you so much for your comment. And now the floor is open.
So sorry, Elif. Just one quick comment.
Yeah.
I think this idea of emergence make people think about having no attention to things and justify the wrong way of dealing with their practices because we have an emergency. So since we have emergency, we can use placebo in any way. We can use people in the clinical trials not very careful about the risks. And okay, that's my idea. I think this sense of emergency or fasting, I don't know, so sorry for my poor English, but this sense of urgency make people justify their not thinking about ethics or moral issues? Thank you.
Thank you so much, Nisa. You don't have to apologize for your English. It is perfect. I think we all understand what you want us to say. And I completely agree about the emergency and ethics dilemma. You know, from that point of view, ethics is something that we only address during normal times. But if it is emergency, then who cares about ethics? You know, it's emergency, so we have to do what we have to do. I think that's a very dangerous way of thinking. And I think it's against the whole issue of ethical values, principles, and so on. So I see Professor Silverman unmuted. Do you want to say anything, Professor Silverman, at this point?
No, that's okay.
Okay. So with your permission, the floor is open for discussion. If any of our attendees have any questions or comments, please raise your hand. And our host is Dr. Banu Brook, and she's going to give you the floor.
Actually, right now we have no raised hand.
Okay, so everybody's overwhelmed with the discussions and the presentations.
I want to say something else, Elif.
Sure.
That might be relevant to the discussion on the emergencies.
Yeah, please go ahead.
Having worked with UNICEF in the past, I realized that emergencies also create a window of opportunity for change because of the injection of resources. However sustainable they may not be at that, they might occur after the emergency and they don't last forever. But if they're politically managed well, they can also provide tremendous public health boost to the country. This actually happened in the case of Turkey after the Marmara earthquakes. And